So physiological assessment, basic steps and to recognize and avoid pitfalls. So you know the limitation of the coronary angiogram, which is a luminogram. So you see from one plane it looks significant, the other plane doesn't look significant, and focal narrowing and diffuse narrowing it will be difficult to make out from the angiogram alone. When you do physiological assessment either by FFR or the non-hyperemic pressure ratios, it exposes the functional aspects. It is affected by the epicardial anatomy, the perfused territory extent, the microvascular resistance, and the collateral flow. The anatomical severity which we assess by angiogram is just only one component. So physiological basis, I am not going to those details. We know it is the final formula is PD by PA. The PA is the aortic pressure, and the PD, which is the pressure which is obtained from the pressure wire. The parameters affecting FFR or non-hyperemic pressure ratio, technical factors and patient-related factors. This is because I am telling all those details because this is a teaching session. I know that most of you know all these things. But still, as a teaching session, we have decided to start from the basics itself. There are common technical pitfalls during physiological assessment, like during preparation, during measurement, and during tracing interpretation. There can be gate catheter related issues also. So preparation of the pressure wire, remove the wire from the package, keep the wire in the loop, flush with saline, wait for some time for the wire to get wet. And next is calibration. Calibration is teaching the pressure, teaching the systems what is zero pressure. For that, we should know what is the phlebostatic axis, fourth intercostal space, mid-chest, regardless of head elevation. And the catheter position should not change once you have calibrated. The zeroing of the PA or the aortic pressure is open the transducer to the atmosphere, zero the hemodynamic monitor, and then zero the PA on the console of the FFR or the IFR machine. The pressure wire zeroing, keep the wire at the level of the transducer, connect to the console and zero it. Then you have to give nitrates, 200 microgram intracoronary before introducing the wire. This is to prevent whatever spasm is which is there in the vessel, and also to prevent the epicardial vessel spasm which can be introduced by the wire. Then the equalization. Equalization is teaching the two systems to be synchronous. So to equalize, you have to push out the wire. Just the transducer should be out of the guide catheter. You know the transducer is at the proximal part of the dark end of the wire. So you have to push just out and then do the equalization. You can see that the pressure, that there was a difference initially which overlaps towards the end once you equalize. So always remember, don't equalize with the introducer needle in place, because there is a subtle leak, 10 millimeter difference can occur, which may affect, because we are looking at borderline lesions. A value of 0.78 or 0.82 will matter. So these steps are very, very important. To HEVOS, you have to tighten it. All the connections should be very tight. Otherwise, minor leaks can lead to very subtle variations which can affect your values. And once you have fixed your transducer, never change the position of the transducer. This is so our patient where we have raised the transducer by 2 centimeters and put down the transducer by 2 centimeters. You can see the gross difference in the pressures. So never change the position of the transducer. That is where the stopcock or the three-way opens to the atmosphere. That is the level of the transducer which has to correspond with the phlebostatic axis. Then always, whenever you do measurement, flush the catheter before any measurement, because you have blood, you have contrast, which can dampen the aortic pressure. Wire position should be very, very important, because it should be at least 2 to 3 centimeter, at least 1 centimeter distal to the lesion which you are assessing, because there is something called pressure recovery, which I will show in the next slide. And ensure that the wire tip is rotating freely and there is no resistance felt when the torque is applied. And it should be preferably in a vessel which is more than 2 millimeter in diameter. And if you are putting it in a small branch, it can produce something called a whipping artifact. Distal wire placement, as again seen, thanks to the slide from Vijay Kumar. So this is there will be the pressure recovery just immediately after the lesion. So you have to measure it much distal to that. Hyperemia, nitroglycerin should be given to dilate the epicardial vessels. Then you have to give the adenosine or whatever agent which you use. Mostly in India, people use adenosine. There, it was initially thought that we should give only in the central vein, but now we have data to show that you can give it in a good peripheral vein also. Only thing is that the onset may be slightly delayed. And there are certain drugs which can affect adenosine metabolism, like theobromine, theophylline, caffeine, and even ticagrelor has been found to affect the adenosine metabolism. And caffeine, we can always avoid. History of caffeine intake should be obtained, and patients who are undergoing the physiological assessment can have can abstain from caffeine for at least 12 to 24 hours. Next is FFR in osteal lesions. The equalization should be done in the aortic sinus, because once you place the wire in the coronary, it may affect the basal FFR values, which in turn affects the final values. Hyperemia, osteal lesions, intravenous is always preferred, because when you give intracoronary, we may not be able to deliver adenosine, because you have to engage the guide, and when you partially engage it, part of the adenosine will be lost, and it can the guide catheter can contribute to the stenosis. Guide catheter related issues, you should not put the guide catheter, especially if it is an osteoproximal lesion, it should not go deep inside, because it can give erroneous values. Side holes, it is better not to use the side holes. The full drug may not get delivered, inadequate hyperemia, and always there can be a flow from the side holes to the tip, which can create a gradient. And if the tip is intracoronary, the pressure may be a hybrid pressure, the aortic proximal and the distal pressure, distal to the lesion. Another important thing is wedging of the guide catheter. Very, very, very important. You can see that the initial part, it was a correct tracing, but subsequently when the guide catheter got wedged, you can see that the pressure tracing changed. So if you see the distal part only, then you may think that the FFR is negative. So another example, the guide catheter engaged and guide catheter disengaged. So always when you measure FFR, especially when there is an osteoproximal lesion, always disengage and measure. That is the most apt thing to do. So what to do when there is wedging? Check the aortic pressure tracing. If there is wedging, disengage and measure. Always give judicious nitroglycerin in between to reduce catheter-induced spasm, and better to shift to IV adenosine. And as I said, FFR better to be assessed after disengaging the guide catheter. Errors in measurement, when should you measure FFR? That is always a question which we don't have a clear-cut answer, but it is said that you should wait for the steady state when the resistance is fixed and minimal. If you are giving IV adenosine, better to track the PD by PA during hyperemia. Wait for stable signals after 45 to 60 seconds of infusion and select the lower FFR value. It is said that after 2 minutes, the effect of adenosine wanes off. There is something called smart minimum FFR, which is an automated thing in some of the machines. Always check the cursor position. Simple thing. The cursor the machine automatically goes to the area where there is a maximum difference. So it may not be, as you can see, the initial part where there is no aortic pressure tracing is not there, but still the machine detected that was the area with the maximum difference, so it was taken. So always check the cursor position when you measure the FFR. Beat to beat variations can be there due to either spontaneous respiration, coughing, arrhythmias, or exaggerated respiratory activity. Then most of the machines, the default setting is the single beat is the default setting. It can sometimes underestimate. So it is recommended that you change to a 3 to 5 beat average FFR. As you see in this, you can see that it varies from 0.75 to 0.68. But when you use a 3 beat average FFR, you can get a stable value of 0.71. Pullback verification, I think it was demonstrated. I think it is the most important step when you are doing a physiological measurement. Always do it. Otherwise, if you are not doing it, you are doing a injustice to the patient. Always make sure that you do a pullback at the end. In this case, it was 0.99 and the value should be 1. You should aim for a value of 1 for an ideal pullback measurement. Then only your value is correct. So if the mean value is less than 5 millimeter, this difference should be taken into the account of the calculation of FFR. I will show you how it is to be done. When the difference is more than 5, the mean pressure difference, the last measurement should be repeated. So how for example, if your FFR obtained is 0.79, when you pull back, you got a value of 0.96. Ideally, you have to correct it by dividing 0.79 by 0.796. So a 0.79, which is a positive value, has become 0.82, which is negative. So that is what. So it is very, very important to have the pullback. Why there is a difference? This is what is called a drift. Drift is the resetting of the baseline pressure signal, because it is a problem of the piezoelectric pressure sensors. So this is what happens in a drift. You can see the initial part, and the red is the aortic pressure, the yellow is the pressure wire pressure. You can see that there is a dichrotic notch in the aortic pressure, the wire pressure doesn't have it, but subsequently without doing anything, this was recorded without doing anything, you can see that the morphology of the pressure tracing changes to similar to the aortic pressure. That is called a parallel shifting. And this is from technical characteristics of the piezoelectric sensor, which is electric in origin. So you cannot do much on that. So what are the clues to a signal drift? The clues are the distal pressure may be higher than the aortic pressure. The distal pressure is unstable and continues to drift. Distal pressure is lower than the aortic pressure but retains the identical waveform. That is called a parallel shifting. Even the dichrotic notch will be visible in the distal pressure. Mechanism of drift, there are many mechanisms proposed. Moisture in the connectors, micro bubbles can get trapped inside the sensor casket. This problem is not there in the optical fiber sensors, and temporal mediated. So the gradual degradation of the signal, or the temperature mediated, because the temperature can go up when the wire goes inside. These are some of the proposed mechanisms. This is the rapid exchange FFR microcatheter may not have such a problem to that extent as we see with the usual piezoelectric wires. So what to do when the drift is recognized? Pull back the wire into the guide, equalize again, and always make sure that the pullback pressure value is 1. Coming to patient-related factors, can you do it in a STEMI? We know that in a STEMI situation, the microvasculature is already compromised because of the clogging or the factors released during MI. So you cannot do an FFR assessment in the first 5 to 7 days. The culprit vessel cannot be assessed, but in a non-culprit vessel, you can assess at the time of a primary angioplasty. For example, you are doing a primary angioplasty, you find a borderline lesion, you can do an FFR assessment of the non-culprit vessels, because it has been found that the values remain stable over a 3-month period. Scar tissue, this is an example. For example, the upper panel shows an FFR value of 0.6. This patient was waiting for a procedure, developed an MI, and lost a significant amount of myocardium. So subsequently, when it was measured, the FFR was 0.8. So the FFR normalizes for the perfusion area. That is why we don't get, even if it's a very tight lesion, we don't get positive FFR in a small diagonal branch and all. So it always normalizes for the perfusion area. LVEDP can affect FFR. High LVEDP, because we know LVEDP impedes the myocardial perfusion. So high LVEDP functionally creates microvascular disease, which is known to cause inflation of the measured FFR. LVH, gross LVH, can also affect FFR. Then another aspect of is the impact of right atrial pressure on fractional flow measurements, because right atrial pressure, usually in a usual situation, the FFR is indeed found negligible. So I will show you an example of the right atrial mean, the influence of right atrial mean on this pressure. When the pressure is, aortic pressure is PA is 140, PD is 115, and RA mean is 5. If you use the formula PD by PA alone, it is 0.82. But ideally, what is ideal formula? It is PD minus PV by PA minus PV. So if you use that formula, it is 0.814. When the pressures are normal, RA pressure is normal, the values will not differ. But in the lower panel, you can see the RA mean is high. Patient in congestive heart failure, there is a low blood pressure, 80 and 65. You can see that the values, when you use these two formulas, it is 0.81 and 0.76. So how will you practically do it? So validating practicality, this was an article. So you can see that if the patient is hypotension, or the blood pressure is on the lower side, and the patient is in heart failure. For example, when the CVP is more than 15 and the aortic pressure is less than 80, you have to include the RA pressure also in the formula. Collaterals from the donor artery, the FFR values may be low in the donor artery, it may become false positive. I'll show you an example. So what you should do is revascularize the donor artery and revascularize the recipient artery and reassess the FFR in the donor artery. If it is still positive, revascularize. And if the Rendrop grade 2 and 3 grade collaterals are there, the values can differ up to 0.1. It is very, very important. And grade 0 and 1, it may not matter much. So this is an example. On the left side, you can see that the RCA has a significant lesion. The LED collateralizes it. But the F value measured in LED was 0.75. Subsequently, the RCA was revascularized. When you measure the FFR again in the LED, it is 0.84, it has become non-significant. So this is what the collaterals given to the RCA is affecting the FFR value in the LED. So what is the amount of myocardium is the determining factor from all these things which I have shown. Accordion can affect the FFR because it produces something called as pseudostenosis, but actually it can be physiologically significant. And one slide about the non-hyperemic pressure ratios. The resting ratios need to be measured in the true resting state, as Dr. Johnson was mentioning. Wait 30 to 45 seconds after contrast, saline or NDG, because all these can produce some form of hyperemia. Otherwise, the residual hyperemic effect will artificially low the IFR, RFR or DPR, etc. And we also should know that diastolic pressure ratios, the coronary flow may be also happen in systole, especially in RCA. So purely diastolic flow ratios can be erroneous. That is another big topic which we will discuss. Other issues like tandem lesions, left main lesions with LED circumflex, all those are because of the lack of time I will not be discussing. So to conclude, ladies and gentlemen, the FFR or a non-hyperemic pressure ratio is just a bare number, and this value may determine the future course of your patient. But the only guarantee on the validity of these values is the careful training on the steps of measurement, which is very simple. Awareness of the potential pitfalls and artifacts which I have mentioned, continuous quality control of your FFR practice, and the most important is know your patient. Know the symptoms, history, ECG, echo stress testing. Because we know we have a gut feeling that this is likely to be significant, then you have to relook at the measurement which you have done. And always, I insist that always do a pullback when after you measure, complete the measurement. Thank you.